Until you put the headset on, you're never going to appreciate what this technology has to offer. The patient is the one that benefits. The challenge becomes the surgeon's ego. Surgical or medical intuition. Yep. What the hell is it, and how can I train it? Pseudo-intuition is this fake sense of security that us doctors have, that I think I diagnosed this guy the right way, or I think I did the perfect surgery the right way. The piece that we miss a lot is...
Today's conversation is with Dr. Joseph Krajekian. He is an oral and maxillofacial surgeon. He's also a bit of a pioneer in the VR space. For his undergraduate degree, he went to California State University. Then, for dental school, he went to Tufts University out of Boston. And then, as if he hadn't had enough pain, he went from there to medical school at Drexel in Philly. And he finished off with his residency in oral and maxillofacial surgery in Pittsburgh. Today in our conversation, we touch on how he uses virtual reality with both patients and residency training. A theme that ran through our conversation was feedback. What forms of feedback do we have within medicine to inform our intuition? Or if the feedback is off, is it a form of pseudo-intuition that we have? Anyways, it was a terrific conversation with Dr. Krajekian. And if anyone wants to learn more about immersive touch or how he uses VR in surgical training, you can check out some of the links below.
When I introduce virtual reality, or the concept of using virtual reality in medical training or care, it seems a bit controversial to lots of institutions, especially when they talk about the idea of training in a virtual environment that is not perfectly harmonious with the real world. And that can seem controversial. It seems like people are picturing you going from never having operated on a person, you did heart surgery in VR, and then you just hop right over to the real person. How do you think about the use of VR, or is that subject controversial to you?
Not at all. I think we've been using VR. I've been using personally VR for the past 5 years. And almost in any major surgery, we took VR into really 3 components or 4 components. The initial imaging, or the initial idea that I can look into pictures in VR, was beautiful. You know, it's like when the concept of the 360-degree lenses came, that you can put your phone in there and look into the world, and 360 degrees, the VR experience. It was great, but after doing it for a period of time, it gets boring. And it's exciting initially, but unless you start being immersed in it and interacting with it and working with it, not statically, but very dynamic, and making it a patient-specific, things shifted. That's where, but about 3 years ago, we're now no longer looking at the data as a static, 3D picture of a patient's skull. My area of expertise is head and neck as a maxillofacial surgeon. It's not just me looking at immersing in a 3D picture, but now what can I do with it? And that's where I think significant amount of the element came into play, and how it became very useful. So I look at it as, okay, I can see this. I can show the patient their issues, their deformity, their tumor, their cancer, or their facial deformity issues, or their arthritic change in their joint, or their obstructive sleep apnea component. And now I can not only engage the patient and show them, but I can actually make the rehearsal. So what I call is a rehearsal surgery. So now I can manipulate the surgery in the real world specific to them, with them being with me in the room, and we're engaging together. So now they can see me doing the surgery with them, specifically to them, based on their own anatomy and customized element. But the other portion is whatever I VR, whatever I do in immersive world, we're taking that, and we have an engineers out of Chicago that take the data that we decided, and they create custom 3D guides for me. So now so if I'm doing, for example, if I'm doing a resection on a patient, when I'm taking half their mandible, right? The objective at the end is to give them back to what they started with, right? So now we identify the tumor in the jaw. I identify where my margins are going to be based on the overlaying CT scan, and I'm immersed in it, and I show them, here's the nerve, here's the teeth, here's the occlusion. we're going to attempt to sacrifice the nerve, or we're going to attempt to preserve the nerve based on, where the condition and the tumor and the lesion is. But here's what we're going to do. We're going to make sure we maintain the contours of the face to look the same. So I'm going to maintain my contour so I can mirror the left side on the right side. And I can see where the contour of the jaw should be. So you're not looking incredibly disfigured. Because, the face is reflective of who we are. So the goal is to give him back what we're taking away. So we can plan all of this in VR with the patient. And then we take that data that we plan into the engineering world, where we have these biomedical engineers that we partner with, and they can create a custom resection guide where now I don't have to look at the tumor. I don't have to do margins. I don't have to worry about all these things, because now I have specifically a guide that tells me where I need to make my incision, where I need to make my cut. The tumor is inside the jawbone and it's not very evident. And they can tell me exactly when I need to do the resection. And not only that, but I can align the bite. I can align my custom plates that they will draw for me, and I can replicate it in the OR. And the biggest thing is, but the benefit to the patient is massive. So there's a whole component of surgical VR manipulation, surgical rehearsal, and then reconfirmation. So we take a CT afterwards. We send it to the biomedical engineers. They overlay it based on what the initial plan was, and we'll see how good we are. So unless you have your own feedback, you never know if you're improving, or you're just maintaining the status quo, what you think. I don't want to know what I think.
Or whether a patient complains or not.
Right.
So it's a deeper feedback mechanism rather than just does the patient say anything or not a year or 2 years later.
Exactly. And the idea, you look at the contours, you're looking at the overall, and the face is so, you can't screw it up, because if you do, it becomes evident.
Yeah.
So, and especially when you deal with the maxilla or the mandible, the jaws are, if you get a filling done and the filling is a millimeter off, you know about it. We don't have a lot of give. So we have to make sure everything is perfect. Now, it's from a resection standpoint. If we're doing a joint, like we're doing a TMJ joint, that adds another complexity, because there's probably 50 to 100 surgeons across the country that do these, and there's probably about 700 to 800 cases done a year. So these are very meticulous, pre-planning and finding out what joint do you want to do, what size, what structure, how you want to resect, how are you going to drill bone, and we can do all of this preparatory work in VR before we actually go to the real world. So this is the surgical component of VR, which also plays as part of patient education, right? So patient education / consent, that's what I'm referring to it. Then you're talking about surgical rehearsal. Now we take this to the teaching phase, where we can do, kind of a resident teaching, where we talk about morbidity, mortality, risks, complication. Oh crap, things went wrong. What are you going to do now? Or we can create case scenarios where I can, in VR, I can take a patient CT scan, I can create a pseudo tumor, and I say the tumor extends from the condyle all the way passing midline. How are you going to resect this? Walk me through the details. And if you want to take a piece of bone from the hip or the leg, we can CT the leg, and I can overlay where you're going to do the resection as a free flap from the leg to the jaw, and where you're going to put the dental implants in there. So we can play out all these scenarios from a surgical consent, patient education, surgical rehearsal, and also academic education, and also kind of morbidity, mortality, and kind of a board style questions. What if? So you can see how this all plays out.
Okay, great. And so to make sure I've understood that, you're saying you'll go from a situation where you'll meet with patients, do all the kind of consultation initially, but then from that comes some scans. Those scans are digitized and made into a virtual environment, so that when a patient comes into your office, you put on a headset. You're, I'm guessing, casting that to a TV in your office, right? And they're watching you go through the surgery.
Correct.
That they're seeing the some of the process as well as some of the problematic or sacrifices or gives and takes that might be made during a surgery. Are there any decisions that are made by patients during that? Like, will you consult on particular aspects as they're seeing it and say,
and when a patient signs a consent form, and
Yeah.
this is a question: how much do they really understand?
Yeah, absolutely.
And I think we were looking to put a paper out as like changing the model of patient consent. Patient consent should not be paper, should be visual. And what a beautiful way to create a visual consent with the patient where they see their anatomy, they see how their bite is going to shift, they understand the facial deformity it's going to look, and they get it. Like when we do some of the cosmetic patient where we have facial deformity, where their mid face is completely sunk in, or they're very prognathic, or they're significantly underdeveloped, where they have very a compromised chin position. These patients have a significant amount of desire that they want to look normal, whatever normal is. And we show them, if I bring your jaw a centimeter or a centimeter and a half, here's what it's going to look like. Here's what it's going to look like if we do half. Here are the angles that we look for, what's considered appropriate based on the population data. So we show them all these dynamic, and they understand. It's like, I like my chin position here better. I like my upper jaw smile looking good. So they're very engaged versus me just projecting what I think they need.
Versus just a list of possible effects and selecting kind of between those. They're actually seeing it, which is
they're seeing it,
which is very interesting to consider because probably I wonder the paper you were considering writing in this area or working on. Generally, you were trying to explore the idea of what effect does more informed or even visual consent have on what outcome were you interested in?
My interest was to do with the patient expectations and patient compliance, right? So the big thing becomes is, when a patient has to go to an 8 or 10-hour surgery and the family is involved in it, do they truly understand what journey we're embarking? Because none of the surgeries of that complexity, you do one and you're done. There's a tremendous amount of pluses and minuses, and sometimes they got to be revisions. The goal is to get it all in once, and majority of the time we do. But at least it make them more informed. They understand why post-operative compliance is so critical, because now they understand why, right? They understand why we want to engage, for example, in TNJ patients, why we want to give some Botox to the facial muscles to weaken them, so I can allow osseointegration of the screws, because most of them are parafunctional. They start to recognize why braces are important in these dentofacial deformities, where we're bringing the upper jaw, lower jaw, we're aligning them. Why do they need braces for a period of 6 months to a year afterwards? Why they need rubber bands? They're not going to be wired shut. Why do they need to be wired shut in some circumstances? So they get to have a greater understanding of the surgery, the appreciation, and most likely minimize, post-operative complication, and also provide more medical legal understanding of things. Because how many patients where, I didn't understand there's a risk of permanent numbness, or I didn't read that, or they rushed me to sign it. The idea is, how
seeing the nerve, seeing how close what you're doing is to a particular nerve, and going through the risk benefits of saying, now, if we're going to try and keep this nerve or preserve this structure, there are challenges, those types of things.
Correct. And this is, you're exactly right. So any permanent long-term risk are the ones that we, always have to be careful of explaining these. But I think it creates that better trust between the doctor-patient relationship that to me is so sacred. Because when you have that level of trust, they know your intention is to serve them the best way you can. And that's what we're aiming for with these sets of interventions or utilizing technology to help. Now, what I do see later, which we're working on, until you put the headset on, you're never going to appreciate what this technology is. And there's only probably 50 of us in the country now that are utilizing this.
Yeah, how you're one of those 50, but not just first. I wanted to emphasize a point that you're talking about. That you said earlier that you need to see to appreciate, and it's one of those fields where there is such a large disconnect between where the hardware technology really is and where the public perception of it is. Because I think for someone who maybe dabbles in just hearing VR in the news, they might see something like, okay, Facebook switched their name to Meta. Oh, well, that's interesting. And then they might see Meta's stock price plummet 80% or something like that. And that might be their perception of what's happening in the VR space. Or they've seen a few videos, and it's one of those things that until you've really gotten in and you've seen it, you might have those experiences where you saw that first panoramic photos that we could take with our phones earlier on, and that was a really neat experience. But until you've gone in and interacted with it and had a feeling where you felt like you were present, it's very different unless you had that experience. You've actually hopped in.
Completely. And in the world, as far as we know, there's only one company that allows you to be not only immersed, but interact, meaning I can do a resection virtually. I can position the jaws in one place to another. I can take a plate and put it in. I can take a dental implant and put it in VR. These immersive, engaging option, until then it was, yeah, it's nice, but it's, I mean, most of us surgeons were trained. We can take a 2D CT scan. We can visually make it a 3D. I mean, and now you can ask for 3D processing after the scan to give it to you. But until you start manipulating the data on your own without a need of an engineer to do everything for you, it took this to a completely another level. But it takes. Go ahead.
And is that so? You build the 3D model, it gets built, you can show the patient there, you make some decisions with them at times, it might adjust some of the surgical planning. Now, is the digitization of that scan what allows for the more precise models or implants or whatever you might call them to be made in particular surgeries? Is there kind of like that overlapping utility for those scans being digitized? Is that what they're doing? Okay.
Correct.
Okay.
So they're taking the CT data. You can do it. The details of it depends of what you're looking for. But as long as you do 0.5 millimeter to millimeter cuts of the CT data, bone window, then you can go 3D model. And in that 3D model, we tentatively design the surgery, meaning this is what I'm looking to obtain. And after we design all this with the patient, the next phase would be a meeting with the one of the engineers of the company, and the company we're referring to is Immersive Touch out of Chicago.
Thank you.
And then we relay a data set. What I want the upper jaw to move this much. I want the lower jaw to move this much, and they do all the detailed technical numbers. But I don't have to be preview to that. I'll just meet with them for about 5 to 10 minutes. I look at their 70-page report data, and I make sure everything that I want matches surgical, precision that I'm looking for. And then they give me the data of everything they did back into a VR file.
Yeah.
And I can look at the pre-op, I can look at the post-op, and I can immerse myself into this. And if I like it, great. Then they 3D print the guides for me in a matter of 24 hours. So we can take a patient that I saw today, and we can operate on them with all these technical details by Tuesday.
Wow. And not to mention, because you brought in, and I want to shift a little bit in our conversation to the training aspect, but you brought in the idea that every patient you work on where that data is digitized, they become a case study for you, essentially.
Sure. Yes.
Right? And so then you grab that data, you operate on the patient. 24 hours later, they could technically be as well a training for residents that are coming. Are you training residents on how to perform surgeries or what to think during?
More the latter. How to think and how to be able to predict and how to be able to adapt. That's a greater skill set, because the rest of it, the mechanics of training step A to step Z is pretty straightforward. You memorize it, you can figure it out. But not every patient is the same. Not every case is the same. So my role at this point, when I want to train the residents, when we do our board simulation courses, is how I'm going to teach you to adapt on the fly. That is what I'm interested in. And that sense of surgical or medical intuition,
Yeah.
what the hell is it? In the process of it all, there's a human behind it while maintaining that empathy. That's what I'm after. And hopefully one day we'll be able to make a big impact on how this plays out.
Yeah. And so much of our intuition, well, so much of our training and learning is didactic. In earlier years, I mean, in surgical specialties, that probably shifts more and more and more. Or I'm not exactly sure how that shifts. Maybe you could comment on that. But I'll finish this thought that so much of our intuition is really about seeing things and pattern recognition and associations as you're seeing things, because maybe when you're in a surgery and you see something, it's a different experience than when someone is just telling you an experience. And maybe learning in the proper context might enhance that intuition in surgery. Is that what do you think?
I think you're right. I think, what is intuition, which is a whole conversation of itself. So I think there is a benefit to throwing these curveballs, and the best way to learn it is if you're learning it in the virtual space, because then the price is too expensive. Mm-hmm. And that's the pieces that you cannot afford. And what I think VR and later on can AR or mixed reality down the road can play a massive role in really minimizing these, or even adding AI to it as you're doing every little pieces of it. It's just giving you that immediate feedback. That's where I think AI can massively play a role down the road with regard to our surgical execution. It measures the angle in which you're putting the screw. I think if you angle it, at 5 degrees, but if you angle it at 10, you're going to be able to miss the nerve, or you're going to engage better quality bone. That's where I think that feedback can really play a massive role. But for now, I think the feedback you get is you did your rehearsal surgery based on a pre-planned execution from the biomedical engineer. You take a post-op CT scan, which I encourage every surgeon to do. You compare and contrast in VR, so is what you planned met the expectation. And if so, that's where your intuition will really be playing a massive role in how do you improve.
Yeah, exactly, because that's a great part. So if I heard you correctly there, you're talking about informing your intuition, really, because our intuition is something that we really develop over time. But if we don't have appropriate feedback mechanisms, we might think our intuition is being appropriately taught or guided or developed because no one came back or something like that. That experience. I mean,
you're absolutely right.
In clinical medicine, that's often the case. Well, I gave such and such, and they never came back, and so that infection must have gotten better in the way that I thought it should get better. But you're talking about a different type of feedback, which is much more objective, less subjective, to inform your intuition.
Correct. And that's specific to you, to the case that you spent 10 hours on doing, and you're looking at the feedback 24, 48 hours later. You know it.
Yeah. And another aspect of AI that I'm interested in, well, yours is that one use case is fascinating because as the ability for AR, so for people who are listening that maybe kind of aren't familiar with some of these terms, so VR, when you put a headset down over your eyes and you're surrounded by a virtual clinic. AR and MR is when you are, we'll talk about AR, that's the most easiest to understand, but you're seeing the real world, but there's a lens overlaying that is projecting images and data into your field of view. And the use case of being able to have the 3D scan in advance with the AR looking at the patient and then some machine vision watching the angles based on the 3D scan is quite interesting.
And that's we're not there yet, but it's coming.
Yeah.
Right?
Yeah. But I wanted to, going back to the AI, where on the feedback level, it's interesting because you're compiling a use case, a digitized library of all of your cases with really robust feedback. And the idea of AI looking at a system and mining data like that for training purposes is quite interesting.
And it's not going to make decisions. It's just going to be providing the feedback on you as you're doing it. So if I'm doing a tumor resection of a patient, and the nerve is very close, but I can't see the nerve in the middle of the jaw, or I can't see the nerve in the upper jaw. So I'm ready to make my cuts, and that feedback telling me if I angle it a little bit different, I might get a better bone-to-bone osteotomy or better bone cut, which will lead to better outcome, less relapse. So these are the feedback that I foresee down the road. I'll give it 5-10 years for that to be played a role. But that's your immediate feedback to reinforce intuition as you're optimizing your training.
And your post-training feedback could be something like, whenever you load up a patient, you're going to present to that, and all of a sudden, this data is immediately tagged with 10 other cases where there was a similar type of process that was being done or a similar plan, and you can see those 10 and say, oh yes, that nerve is hidden. We keep running into this particular problem. So that type of a idea to inform your intuition is fascinating. But I wanted to shift to the adoption, because you mentioned how there might be only about, you said probably 10 in your field that are doing something like this, but maybe 15 in the country that are doing something like this or using VR in their practice in this kind of a way. How did you get in a position to do that? And because often, as I've talked to a number of institutions about using VR in practice, and often it reminds me of like trying to plan a family event over a group text where it's like, oh, if Uncle Leo can't come, well, can they make it that day? No, let's shift to this day. Then that's on so-and-so's birthday, and we don't want to do the event on that. So there's a whole bunch of, it's just a bit of a nightmare in trying to plan that out. And whenever we talk to institutions, it's, well, what would the anatomy department think of that? Maybe we should get them involved. And maybe one of them's had a bad experience. And so there's a bit of everyone's waiting for someone at an institution to kind of take a leap, even if there's tremendous interest collectively. How did you get in a position to be able to apply this in this way?
So what made it different is, I still operate at the Cleveland Clinic, but I'm no longer employed by the Cleveland Clinic.
Okay.
So in a sense, most of my decisions are made as an independent private practice.
Okay.
But I think more importantly is when the patients start to demand it. That's where I think we'll start.
Yeah.
For example, at the Cleveland Clinic, there's only a few of us that do it. Are you one of the surgeons that uses VR in your surgeries? No, well, I'm not going to go to you. I want to go to the one across the street that does. That by itself will start creating a little shift. The patients demanding these innovations. And I think that's when we will start to see that. But we're far from it. We're certainly far from it. Even the new residents graduating that we're training them, not many people are adopting it. And I don't know the answer to that yet. Mm-hmm. Maybe because the institution they're going into, they're the lowest of the poll with regard to rank, and they're not able to shake the system. Yep. And if somebody's been doing these surgeries for 25 years without it, it's a new little gadget. I don't need it.
Yeah. What role does time play in something like this? Because as I listen to you go through the process, I would want a surgery like that experience. So I've had a few surgeries in my life, and there's a few things I wish I understood that could have been shown to me visually to help me understand that. I was younger as well, but my pre-surgical and post-surgical, it sounds like a more in-depth and more time-consuming process that you're describing here. What effect does time play a role in people's desires to adopt additional things like this?
I think, at the beginning, it used to take a little bit of time on my end. Now I can see the patient do a CT scan. My staff uploads the CT scan to the engineers, and they convert the file for me in VR.
Okay.
I put the headset on. In 5 minutes, I can plan the most complicated surgery, review it with the patient for like a period of half hour. That's my surgical consent, pre-op, and so forth. And then I spend another 5 minutes with the engineer just to confirm the analysis that I want with regard to the surgical plan and the surgical guides. And then it becomes execution. So it doesn't add more time to me anymore. Okay. And I think it saves me probably about an hour to 2 hours of OR time. And that's where I think hospital adoption will really start to go in. Patient outcomes, cost, readmission rate, reoperation rate, success data. And that's what, over time will start to accumulate. And when we start having that enough data to support its validity, then you can start seeing some adoptions like, okay, well, this is the new thing. we have to start incorporating it. It's what the specialty is demanding of us.
Okay. Okay. Now you've mentioned that's the second time you've mentioned data. Who are people that someone who's interested in this should be aware of that's trying to produce more data in the space, more evidence to support its application?
I think that's going to be somebody who's interested in innovation technology, and also, I'm a clinician. I'm not a researcher.
Okay.
So
Yep.
I mean, I'm happy to collect the data to everybody, but I'm not going to be the one to put it together. It's not my thing. But there should be a lot of people who are interested, like a biomedical engineer or somebody who's interested in a research project as an MD, PhD, or a DMD, PhD candidate, and they want to look at the application of innovation technology, VR, AR. I mean, the average minute of OR in the US, if I remember correctly, is about $75 a minute.
Wow.
So cost. So you can imagine if you saved 2-3 hours per case in the hundreds of thousands of cases that institution does a year, you can just add the math. It becomes no brainer. But we need more data to justify its use. And it's coming. I mean, VR in medicine is at its infancy in so many ways.
Absolutely. Yeah, exactly. I feel like, AI has come out of that cycle into the forefront now where there's a tremendous amount of excitement about what people are seeing on ChatGPT. I feel like VR is kind of back in a little bit more of those underground development phases where it's going to pop out in a few years. Things like the Vision Pro with Apple kind of give a little flash for people to start seeing these are big companies. But I think the big reveal is still yet to come, but it's probably going to be the next surprise is going to be a very big one.
I think so too. And I think as the technology and the cost becomes more economical, I mean, can you imagine somebody has a VR headset that they buy for a couple of $100, and at home, I can plan their surgeries remotely.
No.
And with two avatars sitting across, or family avatars, right? And I'm there as the surgeon. I'm seeing patients from California, and I'm in Ohio, and we're doing a surgical rehearsal, a preoperative consent/consultation before we actually do it.
Yeah.
I mean, can you imagine the value of how that's going to play to the personalized care that we're all aiming to give these patients? Personalized medicine. Well, this is a really personalized surgery in a way with a rehearsal preparatory ahead of time.
Yeah, and the preparation is interesting because I do some woodworking projects, and sometimes you can plan something out in the head. You can even plan it down on the paper, but until you get to the project, you're looking at the rock or the wood or whatever it is, and you've got your tools in front of you. You're like, that plan wasn't really that careful, right? And so, what effect has having this available done with your planning? Like, I'm sure you were thorough before, but any insights there?
Well, I think tremendous, because there's so many times you're doing something in the OR, and the beauty of what we do everything in a small scar incisions. So I don't have the whole skull exposed to me as I would like, right? If I can see, I can do, right? Woodwork, because I do a woodworking project as well. It's so easy in a sense because you get the whole project in front of you.
Yeah.
Well, if I'm trying to do a reconstructive surgery on a Lefort and a jaw, and I'm doing these with small little 2-inch incisions, I don't have the whole big picture. I'm working in a tunnel. And to gather that information in a tunnel is sometimes not as clear. So in the midst of the OR, sometimes I unglove, I put my VR, something doesn't feel right. And we see this all the time. And in the past, let me look at the CT scans, let me try to figure it out. I was like, well, no, I'm going to put my VR headset on. I'm going to rehearse that segment of the surgery and see what's my obstacle there. What am I missing? Why is something not looking right? And a lot of it is you're approaching it from a different angle, different viewpoint, and suddenly you connect the dots like, oh, I need to reapproach it. And
so you'll unglove from surgery and you look at the VR rather than the CT sometimes.
Oh, I'm absolutely. Oh, there's no. I mean, but the beauty of it, if I need the CT, I can overlay it on the VR immediately, right there for me. So
you can slice by slice, like you'll have the 3D model and then the slice there.
Yeah. So I can put a VR and I can overlay a CT scan directly on it. So I can see how the VR, how the 3D picture is overlaying on the CT, and I can rotate in various planes. The beauty of it is I am immersed. I can see everything. And it's like, okay, the segmentation that the engineer did screwed it up, which I don't think I've ever seen one. But in case it was, I can look at the original data on the fly while I'm in VR space, overlay the CT scan.
Wow.
And it can show me exactly. So if you want, you can look at the website that I did called the VR Dentist or the VROralSurgeon.com. And you can see some sample videos of how that all plays out and how it really makes sense. And you'll visualize it and you'll understand it.
So coming back to where VR is going, you were obviously an early adopter of this tech. How has it developed over the time that you've been using it?
The engineer, there was a period of time because I was an advisor to the company because we started using it more and more. Mm-hmm. And the beauty of immersive touch, the engineering team used to meet with all the surgeons. So we have about 10 of us or 8 of us. There was a plastic surgeon, there was an orthopedic surgeon, there was a cardiac surgeon, there's a neurosurgeon, there's me, there's a few other people, there's a radiologist, and the engineers, and the CEO and the CFO. And then we used to look, it's like, okay, what features do you need? And we met for a year and a half during COVID, almost every single week. And the engineers didn't think what they think surgeons need, but they heard it directly from surgeons what they need. And they added feature by feature by feature what things we wanted. And the idea is I can put it on. The learning curve has to be so minimal that 2 minutes into me holding your hand, showing your how to use the controllers, you should be able to immerse yourself and be able to do the surgeries that I'm doing. It should be very simple, idiot-proof. And the guys did a hell of a job. Anything we've asked them, they gave it to us. And we reached the place of, okay, I think the next phase we need to look at that we want to invest in is AR. We got what we needed. There's nothing more that I want. If I do, if you want to do half a face resection, I can model what I'm going to do. And now we're talking about 3D printing bone and pec. So I can, take a half of somebody's face and rebuild it to the exact match of what the right side should be where the left is. And I can secure everything. I have a case that we're planning abroad for a patient that has, a facial deformity where there's completely sunken orbits. There's no orbital floor. So all I need to do is build one for them. And then we have the data. So we're going to sit down with the engineers and look at the orbital volume, design something, and then we'll have them 3D printed from PEC. We give them the STL files, and they 3D print it for us. And suddenly we go in on our next mission, and we're putting these in, and I think we're going to see a drastic difference in these cases. And I think there's a value that we didn't really touch on is how does VR work in underserved countries? And I think there's a whole nother venue that I think that can bring in. I can walk, or eventually we'll be able to walk any surgeon across abroad as a virtual consultation training where we can rehearse a surgery with a person across the globe that has never done these cases and walk them through it.
It's terrific.
Or most mission work for surgeons, usually about 10 days a week. So can you imagine, we did one, recently abroad, and we had about 50 CT scans that we requested on patients. So we created a database. Patients were giving us their pictures of what they think they want. And we selected about 50 of them, and we had CT scans done. Immersive Touch was so generous and kind to us that they took all these data and put it in VR for us. And me and another colleague of mine, we went through all these cases in a matter of an hour. 50 cases in 1 hour. Can you imagine the efficiency? 2 minutes a case. And we're looking at surgical rehearsal for every single one. We're going to pick this. We're going to pick this. We're going to pick this. This is the plan.
And you're in the same shared environment? Sorry to interrupt, but you're in the same shared environment, the two of you?
Yeah. Well, no. What we did is I put the headset on and we're sharing the screen. So he's seeing.
Oh, okay, great. Okay, great.
So he's not in a headset. When Oculus or whoever is doing the VR headset, they can do VR headset sharing, which is coming. I think then we really can up the game.
Yeah. That should be one of those things you request. It's happening. So it's happening in ours right now. So again, speaking of third world countries, it's a terrific opportunity, I think, where you can. I'm telling people that in maybe 12 or 12 plus months, we'll be essentially able to import a Western hospital for $230 for the price of a headset, right? Essentially, we're more focused on the clinical skills applications, but essentially you're importing an emergency department for training.
And we have this fear that data, AI is going to take over in a sense. And I think there is such an irrational piece. I think it's all going to be an adjunct for us in optimizing the delivery and the care. But I get the concerns. I have concerns too. But I think from a surgical standpoint, let's put it this way. I don't think anybody's going to trust an AI doing a case. Let's put it that way.
Yeah. But it's interesting. Like, you didn't call yourself a researcher. You said you're not a researcher, you're a practitioner. But I can't help but think of the cooperation that you and doctors that are helping us on our side as they meet with us and talk about what they need as a clinical skills educator. I can't help but see those people as, in a sense, being researchers into this new blend of tech and practice and training and how that's going to work. And one of the advantages to someone like yourself getting involved with a company like Immersive Touch is that, well, you could have looked at Immersive Touch 6 years ago, I guess, before you started practically using it and said, it's not where I want it to be. Come back to me in a few years. Or you got involved and had it become exactly what you need. So that is one of the advantages for the early adopters. So it's interesting. Yeah.
Couldn't agree. We molded, and that's just me. It was just a group of us that we really provided. I mean, some of the stuff they're doing with neurosurgery, if somebody has a brain tumor, what's the best approach that I should do? What's the best window I should do from a skull base surgery? So there's a tremendous value that every specialty brings in. And the beauty of these meetings that we had, we're all sitting on a Zoom call in the midst of COVID, trying to figure out, well, what do I want out of this? How can I envision this working for me? And then you take it a month later, you start doing it, and then you give direct feedback to the engineers. And sometimes the engineers log in and they're seeing the rehearsal surgery, or even I call the engineers, like, hey, look, I don't like what I'm seeing. How can we improvise intraoperatively? And the engineers are on standby waiting to whatever feedback we want. And that interactivity amongst 10 of us, I think, made a tremendous value of how Immersive Touch played such a pivotal role in creating their version 5 that they have now, which none of us thought was even possible 2 years ago.
And that's a good summary for, I think, where I feel like the field is at, where sometimes we look at software solutions and we say, this isn't there yet. But really, the hardware is further along than any of us could have imagined. And really, we need subject matter experts to contribute to the software side of things, to help the field get to where it could be with that type of input. And so that's amazing that you couldn't picture where it is today. But yeah, the collaboration of 10 surgeons on a software like that with a good budget, you could do amazing stuff over a few years.
Exactly. And I think they did. They nailed it. They did a remarkable job. And I commend every engineer that worked on it, because without them being pushed to the envelope to rethink things, I mean, I don't think any of us thought this VR thing is like, oh, great, I can look at things in 3D. Great. It's beautiful. But when we took the element where we can execute, and I can take a joint and I can put it into the TMJ joint, and I can know exactly which ones I need. And they have a library of various joints where I can pick in VR which one I need to do and not rely intraoperatively. I mean, that's another game now that in the past, well, let me see. I think it fits. Well, based on what? The small keyhole that I'm working from? Yeah. I mean, that intuition was pseudo intuition, thinking this works based on what I thought or what the person trained me to think. When in reality now, we're not looking at the intuition as very subjective, but we're objectifying it. And I think that's a whole nother value of intuition, where you're measuring the accuracy of what you thought is right.
Yeah. The pseudo intuition is something I like that phrase a lot, because so essentially one of the things that I like about our application, again, it deals with, we're not in surgical at all. We're in the clinical, and we've mostly been focusing on physical exams from this up to this point in our.
And you're right. Pseudo intuition is this fake sense of security that us doctors have, that I think I diagnosed this guy the right way, or I think I did the perfect surgery the right way. The piece that we, and until you get that feedback, like a radiologist read a scan thinking, well, correlate clinically, right? How many times did you see these reads that says that? But when is the last time they actually look back and see their assessment if this is being a tumor versus not, benign versus malignant? How many of them actually look back a year from now and realize what they read was correct? That's what they're lacking, and that's what AI is playing a massive role with radiology, because it can connect the dots, and that's where radiologists don't have the sense of what biopsies end up being. So their suspicion is not verified, and their intuition is necessarily. And I love my radiology colleagues, but it can be a sense of pseudo intuition unless you have this massive post data to compare things.
Yeah, and again, of course, there's no particular blame on them. It's just that their field is particularly amenable to AI and to big data feedback over time, and so it's a good example for how. Again, I like the idea for how VR used in practice and then big data analyzed, or VR or AI. We're kind of talking about similar concepts right now, but how that can feed back into the loop of training again, where it can be big data that analyzes and finds particular problems in an individual's intuitions, like what you're talking about. Yours is all personalized to the cases that you've done. And then essentially what it is building is a database for training, essentially, to come in and to have specialized training in particular ways to inform that intuition after that. And I'm really interested in that space, where that feedback mechanism, where it goes back into the training. And right now it takes a lot of resources to develop a training for that particular. So for right now, it requires your time. Like, you've got to be there to take students and residents through that training. But it is interesting as that process becomes automated, where we go from, well, here's the data on what you do or don't do, and here's the training for you automatically.
Exactly.
It's a fascinating feedback loop.
Yeah. And I think that feedback loop is so critical, and a lot of our training in medicine lacks it, because it's not part of our culture, right? Like, where how many patients have post-operative facial trauma surgery and they get post-op CTs? They rarely do.
I don't know.
They don't. They don't.
Okay.
It's like, oh yeah, I just put this pan facial, multiple fractures in the face. When I trained, until one of my attendings told me, it's like, now how do you know what you're doing is right? Like, I don't. I think I did it right. Well, think is irrelevant. That's your pseudo intuition. You think you got it. Well, who are you to think?
Yeah.
Give me, objectify it. And when you look at the CT scan at the time, there was no VR. Afterwards, like, oh crap, it doesn't fit. It doesn't match. The beauty of it is, in medicine and surgery, you have a lot of forgiveness. You can get away with a lot.
Yeah.
Right. And that's because, how we're made, and, we're made that we're ability to heal, and your body adapts. There's a lot of forgiveness. That's why we don't have to be that accurate as people think we need to. But that said, there's a little bit of a range that's tolerable. And as long as we're in that tolerable range, I think we will great outcomes. We will be able to have great outcomes. But I think that feedback loop that you're indicating is so critical to our training. And I hope we do more of it, because that's how we're going to shape the next generation of providers and doctors and surgeons.
Yeah. I love that. That's a great place to finish, because I think we're getting near our time. But just wrap up. So we've mentioned a few things. I mean, you've mentioned Immersive Touch, that you do advising for them. For anyone else that's interested in learning more about this, or is there any places that you go? You mentioned some websites for people to go to learn more about this type of work.
Well, the best place to go is to really go to Immersive Touch, and you can set up a session with them. You can look at their website. There's some content that we provide them. You can look at my website, drkrajekian.com. I can show you a little bit of videos of what things to do. By no means is it intended to profile me, because I'm only a player. I'm only a user. The credit really goes to the brains and the engineers and Immersive Touch. And their website is going to be the pivotal of where to learn how to do and how to incorporate adaptation of this technology into your practice. And if it's somebody within the head and neck realm, then they will get me. They might contact me depending if there's special need that they need, and we can share some of our cases.
Okay,
We can do
great.
some virtual session, but go to Immersive Touch. That'd be probably the pivotal place to kind of understand the technology and some of the innovations that they're doing.
Okay, great. And
The patient is the one that benefits. The challenge becomes the surgeon's ego that you got to tamper as you do this, and and I think the humble surgeon, the skilled surgeon that's not threatened by technology, can see this as an adoption, and with the most objective focus being the patient. So whatever it's going to take to help me execute a surgery to the patient better, I'm going to use it. And I'm going to rely it. If it gave me better feedback, a better approach, I'm going to take it. Why wouldn't I? I'll be an idiot if I don't. So I see that being a immediate feedback as I'm intraoperatively is where it's going to be pivotal of what the next generation is going to benefit from.
I see. So you see it filling that gap where right now you're using it preoperatively, postoperatively, sometimes intraoperatively, but kind of outside of the surgery, but you really see it playing a role live with that operation.
Intraoperative, absolutely.
Yeah, intraoperative.
Intraoperative feedback is like when you're doing a cancer case and you're looking for margins to see if you got the the resection and the margins correct, right? That's your immediate feedback. Imagine if you're doing that intraoperatively, where you can take an intraoperative CT scan on a patient while you're operating, automatically have the entire software do all it is on its own, and it's projecting to me, here's where things should be. So patient comes in with a fracture that's deformed. I am reducing the fracture to where it needs to be. And as soon as I get into the right place, AI tells me, you're in the right place, put the plates and the screws. Done.
Yeah.
That's where I can feel
Yeah.
the next level. Hopefully it'll be in the next 10, 15 years, hopefully sooner. And I think we just need to train our providers or doctors and surgeons in a way to be able to adapt. If we can get them to adapt, we can introduce significant amount of these innovations. And I think the person that benefits the most is the patient, because that's what we're here for at the end of the day anyway.
Yeah. Well, terrific. Well, thank you, doctor. That was a great conversation, but we'll end here.